we're going to learn about alterations in central nervous system function and some diseases that are represented there. Briefly at the organization of the CNS, and then we'll get into the pathophysiology. But overarching, you have the brain and spinal cord, you have neurons and support cells, and then we look at the central nervous system, which involves the brain, and then the peripheral nervous system, which are those peripheral nerve tracts that travel up to the brain, sending messages. An organizational schematic of the nervous system. So the central nervous system composed of the brain and spinal cord. And then within the peripheral nervous system, you have somatic and autonomic. We've talked a bit about the autonomic nervous system. Those are the hormones involved in the fight or flight, sympathetic nervous system, and then the parasympathetic, which returns you to your baseline state. And then the somatic nerves are those cranial nerves and the nerve tracts that run from your spinal cord throughout your body. Okay, the main parts of the brain are the cerebrum, cerebellum, and the brainstem. Your cerebrum or cerebral cortex is this outermost layer wrapping the brain, several layers of nerve cells. And we think of that as being responsible for higher order function, consciousness, personality, and high-level info processing. And it is broken into 4 different lobes. Your frontal lobe, which is the last to develop up until, it's still maturing up until about age 24 or 25. And that's responsible for reasoning and planning. If you think about young kids or even into adolescents, teenagers, that part of the brain is not well developed. And so they can tend to be risk takers or making, interesting choices that we wouldn't make as adults. And that's because that part of the lobe is not, the neurons aren't fully mature. Parietal lobe is responsible for interpretation or perception of touch, pressure, temperature, and pain. Your temporal lobe on the sides, that's where interpretation of auditory, so hearing, and olfactory, smelling, stimuli occur, and also responsible for memory. And then your occipital lobe is responsible for vision. Your cerebellum at the base here, that's where the brain processes muscle tone, coordination, movement, and balance. And then the brainstem, which is comprised of midbrain, pons, and the medulla oblongata, that's responsible for subconscious controls in your body, specifically breathing, heart rate, and also sleep. And then deep inside the brain, the corpus callosum is this band of nerve fibers that attach the left to the right and make all those neural connections cross over. So we see some kids that have a genetic anomaly of the brain where the corpus callosum doesn't develop, it's absent, and they have discontinuous movement from left to right. So each side is not communicating with the other. And then the spinal cord, that's where these impulse communications go from the brain to the body and vice versa. So touch is, travels along the nerve endings back to the spine and up to the brain. So looking at all of these things and thinking about it, the clinical use is that if you have a patient who comes in and has had either a stroke or a hemorrhage or some sort of brain trauma to a certain area, then you know that these particular things can be affected. So we see a lot of kids who have in utero strokes, and one of the areas that's largely affected because the blood vessels are still in development, we see temporal lobe and occipital lobe damage frequently. And so we worry about those kids having auditory challenges or being blind as a result of that. If you've had a frontal lobe stroke or hemorrhage, we worry about reasoning, planning, those people can, have trouble with memory, not able to access recent memories, things like that. So these are really important for you to get down and memorize in terms of like, what kind of damage would have what effects in general. So in the brain, we have gray matter and white matter. Gray matter is made up of neuronal cell bodies. And that is all of those higher order functioning of the lobes. That's where all the high level info processing is done. White matter are those bundles of myelinated axons or tracts where nerve impulses travel. And that's in the brain, that's in the core. And then as you move down to the spinal cord, those reverse. In the spinal cord, you have white matter on the outside because it's sending those nerve impulses out to the body parts. And the inside of the spinal cord is gray matter. Here's an image of your spinal cord. You have along the outside the bony spinous process. And then in the very center here, it almost looks like two teeth or something. In the very middle, you've got a little butterfly-shaped gray matter area. And so that gray matter is for processing messages. The white matter along the outside, those are those axons or nerve tracts where impulses travel. And in the spinal process, we call that the pyramidal system. And those axons control voluntary movement. And the movements originate in your cerebellar cortex and medullary brainstem. So you think that you want to move your leg to kick the ball, it travels down the spinal cord through those white matter tracts and acts on it within seconds. Within the CNS, we have the neurocirculatory system. So that's referring to blood flow, circulation, and oxygenation. We'll take a look at the cerebrovascular circulation, the blood-brain barrier, and then cerebrospinal fluid. Image of your cerebrovascular system. The vascular supply or blood supply delivers oxygen and nutrients to brain tissues. Adequate perfusion is going to be critical, right? If you have a blockage and lack of oxygen to any area, cell death can be pretty quickly within the brain. In the interior of this image, where the blood vessels are, in the middle, you have the circle of Willis, and that's just a collection of blood vessels in circular formation there. The key to the design of the brain here is that if you had a stroke or a blood clot on one side, say on the left cerebral artery, blood could flow anteriorly. Collateral vessels could come around the other side to try to oxygenate the brain. And then moving into the brain, blood comes in through the carotids and then drains through the jugular veins. So we looked previously at blood vessels and the endothelial lining that's on the interior of blood vessels. What's different in the vessels in the brain is that the cells of that endothelial lining have very, very tight junctions. And the purpose of that is to protect the brain from harmful substances so that they don't leak into the brain. So the junctions allow transport of small lipid-soluble substances with low electrical charge, but protects you from foreign substances, hormones or neurotransmitters that aren't supposed to be there, and then also protection from environmental fluctuations like rapid changes in blood pressure. Things that do cross the blood-brain barrier easily, water, Electrolytes like sodium, potassium, and chloride. Oxygen, CO2. You want CO2 to be able to travel out, as that's a byproduct of metabolic respiration. And then certain anesthetics actually cross easily into the blood-brain barrier because they meet those criteria of being lipid soluble. Other things that cross into the brain: alcohol, nicotine, and caffeine. And then glucose, which is the brain is the largest consumer of glucose in the body. Brain cells need glucose for energy. And if you get hypoglycemic for too long, and actually it doesn't even take that long, you can start to have brain damage, brain cell death. Amino acids also cross over certain proteins, insulin, and some immune factors like IgG. CSF, or cerebrospinal fluid, is produced in the choroid plexus, which is a structure located in the back or lateral part of the third and fourth ventricles in your brain. And then it flows through the ventricles and around the brain. Main purpose is a cushion for brain structures to reduce pressure on brain structures. And then it's also a transport highway that removes harmful substances like proteins, lactates, and metabolic wastes. And then because it's deep into the brain, it can also help transport important hormones into parts of the brain that are difficult to reach. We each have a normal baseline volume of CSF in the body, which ranges from 125 to 150 milliliters. And your choroid plexus is continuing to make or produce more excess CSF. When CSF pressure exceeds venous pressure, then CSF is pushed over and can be reabsorbed into the bloodstream. That's a unidirectional pathway. Bloodstream volume cannot flow freely into the CSF, and that's for protective reasons. We have some patients that have blockages where their CSF doesn't flow or drain from the brain down through the spinal cord. That can either be from injuries in early childhood that cause hydrocephalus. So fluid can accumulate into the brain, and they have increased pressure. And sometimes a shunt needs to be placed, but we have ways of measuring the pressure in the brain and taking extra fluid off if we need to. So because of that tight blood-brain barrier, excess fluid can travel from the CSF over into the bloodstream, but not the other way. So imagine if those systems were open and blood flow, excess fluid in your hemodynamic system could cross over into the brain. What would happen? I mean, you would have these massive fluid shifts in the brain. If you were dehydrated, the effects of that on the brain, you would have cellular shriveling, and that could cause brain cell damage. And then if you were fluid overloaded and had fluid from your heme system backing up into your brain, you would have swelling on the brain. So the BBB, the blood-brain barrier, has very tight control because it really has to maintain a constant pressure in the brain. And here's just further explanation of that. That was a question from your textbook. Glucose is the primary energy source for the brain. It's required for all neuronal function. And if you don't have adequate glucose, it would have to be prolonged hypoglycemia and probably an hour or a couple of hours before you start to see cell death, but your body is very motivated to feed adequate supply of glucose to the brain. So it'll start mobilizing any stores that you have, and you start to get pretty quickly, if you miss a meal or miss a snack, you start to get hungry, shaky, agitated. That's your primal drive to feed the body some sort of nutrition, some sort of glucose, and that's coming from a protective measure of the brain. Okay, so here's another book question. What CNS manifestations can be expected when adequate levels of glucose are not available to the brain? Answer: your feedback systems or feedback loops respond to low glucose levels by stimulating the release of hormones that will mobilize the glucose stores that you have. Those hormones are similar to your fight or flight, which is why you have autonomic symptoms. And then if it persists and at extremely low glucose levels, you'll have altered brain function. So we do see something called hyperinsulinism in infancy, and those kiddos can have glucose levels of less than 20, and we treat that as an emergency. But I think in the adult population, you probably wouldn't see this unless someone had taken their insulin and not had a meal, or miscalculated and taken too much insulin. So now we're going to go through altered central nervous system function. So this is the pathophys part. We're going to talk about 4 different types of injury: traumatic CNS injury to either the brain or spinal cord, ischemic, excitation and pressure injuries, and then we'll highlight a couple different examples of that: cerebral palsy, MS, and Parkinson's disease. Brain injury is defined as an impact or blow to the head, which could involve penetration, meaning something that goes through the skull, or could also be from rapid movement of the brain, as in a car accident. Sports injuries are also considered this type of traumatic injury, where either the head meets the head or body part of another member, whether or not there's a helmet on, or you could hit your head on the ground playing sports. Small children are prone to falls, so that would be categorized here. Penetration could be from a gunshot wound or a stabbing or something like that. And then rapid movement of the brain, we think of car accidents where your body is projected forward and then back, or also shaken baby syndrome, so child abuse type situations. Methods of categorizing traumatic brain injury so that we can create an optimal treatment plan. Mild, moderate, severe. So traumatic brain injury, there has to be a loss of consciousness to qualify. If you just hit your head hard and you get a bump and a bruise and maybe even a headache or maybe even a little dizziness, if you don't have that loss of consciousness, we don't include that as a TBI. So mild, and the categorization, it doesn't matter how hard you hit, it's based on your symptoms. So mild, there's the event where you hit your head or you have the trauma to your skull in some way, and that includes a brief loss of consciousness. And most sports type concussions fall under this category. Moderate, in order to be categorized as moderate, that loss of consciousness is not brief. It has to be greater than 30 minutes, but less than 1 day. And then a severe TBI would be loss of consciousness for greater than 1 day. Complicated and uncomplicated, this is not something that we can see externally, so that after an MRI is taken, if you have bleeding within the brain, that is a complicated TBI. If there's no bleeding, that's uncomplicated. So we do have patients with moderate to severe symptoms that can last for days, weeks, months, but they never had bleeding. They just have bruising to the brain. Bruising you cannot see, it doesn't pick up on MRI, only the bleeding does. And then we have coupe and contre-coupe. This has to do with the location of the damage or impact. Coupe means that the injury inside the brain is at the site of impact. So if you're hit in the forehead, you have damage behind your skull at the site of the forehead. Contre-coupe means you have damage at the opposite side. And you would have that with shaken baby syndrome or whiplash in a car accident where you're projected forward and back. Yeah, anywhere that your head is shaken. And so contre-coupe is that injury at the opposite side. Then we have closed head injury versus penetrating or open. A closed head injury means it's all contained within your skull and there's no hole or no opening. A penetrating injury or an open injury would be when the skull is actually, either you have a skull fracture or there's actual penetration through the skull, like in a gunshot wound. What's happening inside the brain at the time of these injuries, you have what we call a shearing or tearing of the long connective nerve fibers that, within the brain where impulses would normally travel. When they're broken or frayed, those neuronal messages can't travel across the nerve fibers. You could have bleeding or not, but anytime there's damage there, you are at risk of oxidative stress. So remember all the inflammation, free radicals, lipid oxidation, inflammatory cytokines, prostaglandins, everything rushes to the area and then you get swelling. Because of that swelling and inflammation, we get disruption in the blood-brain barrier. That can lead to ischemia and hypoxia because you have inflammation and fluid there. So oxygen molecules are not traveling as easily through where they normally would. Excitotoxicity, so the electrical circuiting of the brain is using up the glucose stores rapidly, and high levels of glutamate, this is one of the neurotransmitters that is sends impulses. Glutamate is released when the cells are damaged, and that can cause synaptic dysfunction, and you have a lot of electrical firing in the brain. If this injury is large and prolonged, you ultimately have cell death in the area that's damaged. You have an image of someone experiencing a traumatic brain injury. So the head is projected forward. The middle image, the brain actually hits the skull where the arrow's pointing. You can see it looks like there's some redness, which could be bleeding or maybe a skull fracture there. But the layers of the membrane and CSF that is supposed to protect your brain during normal use can't protect you against an impact. So your brain actually is bumping up against the really hard, bony projections within the skull and can cause a lot of damage. image of that coupe, contre coupe type of injury. The impact site is at the front of the head, and as the head jolts back, you actually see damage at the back of the head there as well. Of the potential outcomes of TBI and signs and symptoms are below. Hematoma is when you have a blood collection. Heme means blood. Toma is like a tumor. That's the Greek word for it. So basically a collection of blood under the skull. And blood can push on other areas of the brain and cause pressure. Seizures happen because of electrical firing out of control. Concussion, that would be the mild symptoms. They can have a skull fracture, loss of consciousness, dizziness, confusion, headache, and drowsiness. So any of those neurologic symptoms that are not normal, these patients often get very, very sleepy right afterwards. Increased intracranial pressure can cause respiratory depression, and it also can cause nausea and vomiting. And worst case, if loss of consciousness is prolonged, they can go into respiratory failure. So in that case, it would be an emergency involving airway, breathing, circulation as your primary goals for care, immediate care. There are a few different places where you can have hemorrhage. So here are pictures of cerebral hematomas. The first image is an epidural hematoma. Epi means above or upon the dura layer. So that is bleeding outside of the brain and outside of that CSF layer, but inside of the skull. So it's still causing pushing, compression, and pressure on parts of the brain. The second image is a subdural hematoma. So sub is below, that's below the dura layer, but not inside the brain. It's outside of the brain tissue, but still causing pressure. And then the third image is intracranial hematoma. So you've got bleeding inside a location in the brain. Here's another image of a hematoma, which is the red splotch on the right side of this image. And in this picture, that hematoma is pushing on components of the brain. If you look down the middle, the dark gray represents the ventricles in the brain, and you can see that they are squished and asymmetrical. So this hematoma is pushing on the brain. And then what they're trying to show you with this down arrow where it says uncal, you can have parts of the brain actually push down towards the brain stem and what we call herniate or push through into the spinal cord area. And that's a grave sign when you've got that much pressure. Those patients need immediate surgery to relieve the pressure. And the way that they would evacuate or remove bleeding like that, they would have to drill into the skull to remove some of that blood so that the brain can shift back into place. Here you have a top-down view. The nose is at the top, ears on the sides. So this person is looking up. And this is an image of a gunshot wound through the head. So you have an entry wound at the top left at the forehead, and it goes through, and you've got an exit wound at the back. So I'm going to give you a couple seconds to think about how is this different from a contained head wound, a closed head trauma. What are we at risk for with something like this, where you have 2 open wounds. So you can have spillage of blood and brain contents outside of the skull, and the biggest risk is going to be infection with an open wound like this. One of the neurologic exams that we do for patients that come in with traumatic brain injury is this tool called the Glasgow Coma Scale. And you can see we rank or we assign points based on your responses: eye-opening, verbal response, and then a motor response. So normal would be eyes opening spontaneously. You get points for that. If your eyes only open to pain, fewer points there. If there's no eye opening, just 1 point. And then verbal responses, are you oriented? So that means, do you know who you are? Do you know where you are? Do you know what happened? Do you know what day, month, or year it is? Other responses, if they are confused, but still able to answer questions, 4 points for that. If the damage is so severe, they may not be able to respond appropriately at all. So just depending on the level of the injury. And then motor response, we ask them to do different movements, coordinated movements, and see if they're able to follow commands. If they are not able to do that, then we do a pain test, a pinprick test. You could just use something sharp. It could even be a fingernail. But do they withdraw from pain? And then if they do not withdraw from pain, or there's no response, those are grave signs. And this test, you actually want to do it repeatedly at different intervals, because the neurologic status can change very rapidly from the timing of that event. So you have that initial trauma, whatever it was, say it's a gunshot wound, and then as the hours go on and your inflammatory response grows, and then you have swelling on the brain, the patient can deteriorate rapidly. So we do these, it depends on the age of the patient and what the trauma was, but we do these neuro checks at intervals. So if it was something pretty severe, I might do every 15-minute checks in the acute phase. But if it's mild and they seem stable, I might do a couple half-hour checks and then space it out to 2 hours or more. This chart is just looking at comparisons between healthy, normal functioning brain activity and activity in the brain after a TBI. So this is actually not in reference to that acute, very, emergent phase. So that other scale, Glasgow Coma, is something you do in that urgent emergent phase. This is sort of general signs and symptoms that we see after a TBI. And this can be in the day or a couple days after, but TBI symptoms can go on for months. So that frontal lobe, you could have lack of focus, irritability, language difficulties, comprehension difficulties. Parietal lobe, if there's damage there, difficulty with reading. You can see down to cerebellum, which is your balance and motor function, difficulty walking, slurred speech. And then brainstem, for sure, trouble with breathing, difficulty swallowing. But a patient that has brainstem damage, you're going to be worried about your ABCs, airway, breathing, circulation. You might have to put in an artificial airway, so some of these patients end up on a ventilator if the damage is severe, just until that brain swelling goes down, and that could be days to a week or two before they are recovered and not everyone recovers fully from a brainstem type injury. I wanted to give you guys a little statistics around traumatic brain injury because I think it's so critically important to know. And this is from the CDC, and there's a link at the bottom there. So traumatic brain injury is the leading cause of death and disability among children and young adults. The leading cause of death for children overall are accidents, and so falls, brain injury type falls are the biggest risk with young kids. If you've ever taken care of babies and toddlers, they're constantly on the move. They're not very coordinated. They can fall over things, off slides, downstairs, things like that. So each year, an estimated 1.5 million Americans sustain a TBI, and not all of them are reported. So this is probably under-reporting. 230,000 people are hospitalized and survive, 50,000 die annually, and then up to 90,000 experience long-term disability from TBI. The risk of having a TBI is substantial among all age groups, but highest among adolescents, young adults, and persons older than 75. So the major cause of TBI in our young people are motor vehicle accidents. And then second, it would be acts of violence, mostly gunshot wounds. And then third would be sports injuries, 12%. And you know, if you ever work in the ER, especially the pediatric ER, the after school hours are when head injuries and head trauma start to roll in. So right after, or after school during sports activities, and we usually have an uptick in kids coming through the ER for this. And then in elderly, falls are a big cause of TBI, and falls actually are one of the top causes of death in elderly. So pretty traumatic for them. So there's, in the nursing world, there's a lot of education that we can give and support for these age groups to try to prevent these things. So diagnosis of TBI, it's going to start with a history and physical. So we need the story that matches the event. If someone just came in with dizziness and plus or minus loss of consciousness, headaches, and other neuro symptoms without the story of impact to the brain or some sort of trauma, we would not suspect TBI. So everything that we do is a little bit investigative as we're trying to put the pieces of the puzzle together. But anytime there's a head injury, we start with a CT or MRI, and that just reminded me that we've actually had parents that have fallen asleep holding a baby and dropped the baby. So when I have babies come in through the ER, even if they look fine and they seem like they're acting fine now, I always do a CT or MRI just to make sure. Sometimes they'll have a skull fracture. So again, even if their neurostatus appears fine, a skull fracture or a little bleeding in the brain, that's something that we want to monitor long-term and make sure that it's healing. If they are having unusual signs that look like seizures, we'll do an EEG. And the EEG test, that's with electrodes that we stick under the skin around your head, and we can measure the electrical impulses. That is not a quick test, so you would stay in the hospital for that, and we would probably do 24 hours at least of monitoring to make sure you're not having seizure activity. If you are having seizure activity, you'll stay longer and we'll treat those. And then we may or may not do an LP, which is a lumbar puncture or spinal tap, to look at the contents of the CSF. And if that's, sometimes it's bloody, and that tells us also that there's bleeding in some area in the brain. Treatment, so Immediate treatment, I put question mark, surgical evacuation of a hematoma. Actually going to surgery would be rare, so you would need to have really compression of those parts of the brain that are pressing on the brainstem and causing trouble with breathing. A hematoma alone causing pressure will not prompt them to go to surgery. And the reason is because surgery is very high risk anyway, and surgery in parts of the brain will cause additional swelling, inflammatory response, inflammatory mediators. So if they can avoid it, they will try not to do any surgical procedure. If the patient is having seizures or electrical irritability, we can do anti-seizure or anticonvulsant medications. Pain medications are definitely warranted here. And then oxygen or airway support if needed. Other immediate things nursing care-wise would be neuro checks and documenting any changes in neurologic status. Other things that we do are like, we check your motor function, so grip strength, whether you're able to balance and walk steady, things like that. Long-term care for TBI, the brain needs lots and lots of rest and recovery. So even if it's just a mild concussion, we have young athletes that can go 6, 8, 9 months with ongoing headaches and brain fatigue. And if they're trying to do schoolwork, that makes the symptoms worse. And so it's really hard for a lot of students because you can get a break from school for a week or two, but then after that, most of society expects you to just plug back in and keep going. But these kids need more time. The brain gets really fatigued, and then students get quite depressed because they're not able to get back to baseline quickly. So they're high risk for depression after a TBI as well. Slow return to activities, and then OT, PT, so our occupational therapy, physical therapy people are helpful. And another thing is like counseling and therapy. We actually do send TBI patients to do that as well. The next category of brain injury is ischemic CNS injury. Ischemic means lack of blood flow, and I think that is modern Latin with Greek roots, ischemia. So in this case, you have lack of blood perfusion or inadequate blood perfusion to the brain tissue, which leads to tissue hypoxia. And that could be from various causes, clots or a clot or thrombus would be focal ischemia. So if you have a blood vessel that's blocked in one small area, then you just have one small area of tissue ischemia and tissue damage. For global or widespread ischemia, you have to have some sort of big event like a cardiac arrest. So if someone has a heart attack and full cardiac arrest, they are not having blood flow, right? If the heart's not pumping, they're not getting any perfusion to the brain. So you would see a complete lack of oxygen throughout the brain. Other causes of global ischemia could be asphyxia. We see this with suicide attempts. SI stands for suicide ideation or drug overdose. And I also see this with drowning victims. The pictures, the one image of the brain on the left, the darkish brain tissue, that's what we want to see on an MRI like this. The bright white spots are areas of tissue hypoxia and then subsequent cell death. So the picture on the left, that's a focal ischemic area or lesion. And then the picture on the right where you have white bright spots all around the perimeter of the brain, that's a global ischemia. So I'm not sure what caused that in this particular patient, but we do see that with asphyxia pretty commonly and cardiac arrest. And then you guys know, because you've studied, hypoxia leads to cell death and tissue necrosis. When we see ischemic injuries, most often it's the sensory and motor areas that get damaged. And so those areas become non-functional. So the person is no longer able to control movement. And motor deficits are contralateral, meaning whichever side or whichever hemisphere of the brain, the left hemisphere of your brain controls the right side of the body and vice versa. And that's what they mean by contralateral. It means the opposite side. So if I have a patient coming in with a history of stroke on the left side of their brain, I know that they're going to have muscle weakness or maybe even absence of function on the opposite side. Diagnosis of this is, again, medical history. You want the story of what's occurred, and then we do a CT scan and MRI. If this is a recent or immediate new injury, we do everything we can to restore perfusion. So whatever is causing that ischemia, if it's a thrombus, we have methods of dissolving the clot with medications, or if there's a big blockage, they can access your artery or vein with a catheter and remove the clot. And then those patients, if the clot is the cause of it, those patients would go on anticoagulants. If the cause is a heart attack, we would do whatever we can to restore cardiac function to get blood perfusing. And then asphyxial type drowning or suicide attempts with hangings, where the patient is asphyxiated and doesn't get oxygen to their whole body. We can do CPR, restore oxygen flow to the body, and those areas of the brain take time to heal. So those kinds of patients end up in the hospital for a long time. Even with an asphyxia injury, you have loss of blood flow. Once you reperfuse the brain, you still have inflammatory injury because the time that the brain is not getting oxygen, you have cell death, apoptosis, that's when the cells pop and die. And then you have all your white blood cells come in to try to clean up, but you have a lot of swelling, inflammation, release of toxins. So the brain is very active with a lot going on. Swelling and pressure can cause further damage to structures in the brain. I take care of patients with hypoxic events. If we know the timing of the event, if it's witnessed and I know the timing, we have a treatment where we actually cool the patient down. It's like packing them on ice. We do cooling blankets to lower the body temperature. It's kind of like putting a pack of ice on a bruise or an injury. What that does is slows the metabolic cascade. It slows everything, all the function in the brain, so that swelling doesn't cause more damage. If a patient meets criteria for that, we cool them for 72 hours, and then we very, very, very slowly rewarm them in that 96th hour. So that 4th day, we do rewarming, and we slowly reperfuse the brain, and we observe for seizure activity. And then long-term care with ischemic injuries, it's going to depend on the severity, the extent of the damage. If they have loss of motor function, they're going to need physical therapy and long-term care at home, or sometimes they go to long-term care centers as an intermediate step between the hospital and home, where they can work on mobility and other things. Other motor activities, I think that if you guys are not CNAs, that you wouldn't think of is control of just hands, being able to feed yourself, control of swallowing, things like that. So patients can, after events like this, they can be at risk for choking if their gag reflex is not intact. So pretty devastating with ischemic injuries. Third type of brain injury is called excitation injury or excitotoxicity. So you know we have neurotransmitters in the brain. Those are the chemical substrates that are released at the end of your nerve fibers through the arrival of an impulse. And then remember that those impulses diffuse across the synapse or junction between the nerve fibers, so transmitted to the next nerve fiber. And it's a cascade that then connects to muscle fibers or some other structure, right? It gets the message across. In excitation injury, some of those neurotransmitters get released rapidly and massively. It's like a tidal wave. So you have these excitatory neurotransmitters. The biggest culprit is glutamate, and that's after brain injury that gets released. And glutamate's the most abundant excitatory neurotransmitter in your CNS system. Why they get released? They get released because of damage to the cell. So the nerve fibers just don't hold on to them, and then they're just free range in the brain tissue. Those neurotransmitters activate cell surface receptors that cause an influx of sodium into the brain, and then sodium and calcium ions, and then the sodium pulls in water, and that causes swelling in the cells and brain tissue, which you now know the brain swelling causes more damage. As this cascade goes on and you have increased levels of intracellular calcium, that's toxic and causes further cell death. So it's this cycle that the brain gets into and can't get out of. This type of event, again, is secondary to that initial trauma or injury. So the whole inflammatory cascade and the excitatory cascade is secondary injury that causes ongoing or worsening brain damage. This type of injury leads to seizure activity. So seizures are bursts of uncontrolled electrical activity that goes on between the brain cells or the nerve cells. And that causes muscle stiffening, twitching. It can cause you to have abnormal posturing. These patients can go limp. They can lose awareness of what's happening. The movements are uncontrollable. And they can also have apnea and stop breathing during these events. And that the effects take hours to days. Your textbook says some effects can take years. I think the years are from ongoing damage to other structures. But typically once we have the injurious event, whatever it is, whether it's hypoxia or trauma, it takes a couple of hours to start to see seizures. Again, because it takes time for the cells in the body to react. So another, in this case, like we would also be doing frequent neurologic checks and watching for seizure activity. And we always want to treat and stop the seizures because that can cause more damage. This is just for your review or to refresh you. The neurotransmitters that are excitatory, that kick off transmission of impulses, are glutamate, norepinephrine, and dopamine. And those that inhibit are GABA. GABA is one of my favorites, the most calming, and then also serotonin is one of those feel-good hormones, and dopamine. Signs and symptoms of excitotoxicity are very similar to all the other types of brain trauma. Headache, fatigue, vertigo, which is like dizziness or like you're falling, memory loss, impaired speech, ringing in the ears. These people can have personality change, loss of control, confusion, seizures, and coma. And then care is just supportive, meaning we offer what we can to control symptoms and allow the brain to go through it and for that healing process to take time. But we would definitely use anti-epileptics to stop any seizure activity. CNS pressure injury is the fourth type of brain injury. And an example of this would be what we used earlier, a hematoma or a blood collection somewhere inside the skull that's causing pressure on other parts of the brain. So we see increased intracranial or spinal cord pressure. You could also have this from increased CSF volume, so something called hydrocephalus, where there's too much CSF collecting or it's not draining, and that you have pressure from that. Blockage of CSF drainage can be from a tumor or a hemorrhage or a clot. There are also congenital anomalies. Some patients are born with anomalies in the brainstem where the CSF doesn't drain nicely. Pressure injury causes cerebral edema, so swelling on the brain. Other causes are space-occupying lesions like tumors or herniation of parts of the brain. So any sort of big abnormal swelling, whether it's a tumor or a blood collection or a fluid collection that causes pressure on your actual brain tissue, is a CNS pressure injury. These patients are going to have signs and symptoms related to increased intracranial pressure, the most common of those being headache, vomiting, and something called papilledema, which means swelling of the eye structures. And that's something that you can only see through an ophthalmic exam. If we suspect something like this, that's we would actually call our optho team to come look in the back of the eye and see if they see edema back there. Eye exam is also part of the workup that we do if we suspect child abuse, if there's been shaken baby and hemorrhage. You also see bleeding and swelling in the back of the eye. So we do use the optho team to help us with that. Increased intracranial pressure, you will also see mental deterioration. So just loss of functioning. And some people have hydrocephalus in relation to tumors and things like that. Again, that's water or swelling in the CSF that compresses down on the brain. Treatments, if it's not severe, if it's just mild swelling, we would wait for resolution of whatever the cause is. So for them to get better, for that swelling to go down. If there's a structural problem or a tumor or something, they may need surgery to remove that to get the brain swelling down. And then some patients who have structural or congenital anomalies that they're born with, they may need something called a shunt, where it drains the CSF from those ventricles if they're blocked and they can't drain. These shunts that are placed can drain that extra CSF down into your peritoneal cavity. Okay, just a real quick review of the peripheral nervous system organization. You have your somatic nervous system and then your autonomic nervous system. Somatic is what is under conscious control. So that is the movements that you want to do and you command your body to do. That's done through peripheral nerve fibers that transmit sensory impulses from your periphery, so from your extremities to the CNS, and then back down from the CNS to the skeletal muscle through motor impulses. Targets are skeletal muscle, skin, and then your sensory organs like hearing, taste, smell, etc. Your autonomic nervous system, that controls involuntary function of organs. For example, breathing, heartbeat, things that carry on without us, without our conscious control. Autonomic nervous system transmits messages from the brain to the neuroendocrine system. And those are the hormones involved, right? Sympathetic and parasympathetic systems. Injuries that we consider when we're talking about the peripheral nervous system are degeneration, so meaning deteriorating or declining, a breakdown in the peripheral nerves or the spine. One example of that is called peripheral neuropathy. You can have traumatic injury of nerves or spine through crushing or cutting of the neurons, and that could even just be a paper cut, or you cut yourself with a knife while cooking or something like that. That's traumatic and cuts the neurons at the skin level. And then you can have pressure injuries, pushing or pulling of nerve fibers, and I think specifically of spinal cord injuries when I think about pulling or pushing with pressure. So spinal cord injury, traumatic spinal cord injury, damage can be from fracture. Fracture is specific to a break in the bone, but could also damage the nerve fibers there in the spine. Contusion, which is a bruising, or compression of the vertebral column, pulling, twisting, or severing. Most common causes of spinal cord injury are motor vehicle accident, and then number 2 is violence, gunshot or stabbing. With a traumatic spinal cord injury, you typically have hemorrhage or bleeding, and then the inflammatory response with swelling to that area. As things heal, you can develop scar tissue and thickening of the meninges that travel along your spinal column, and that can continue to cause damage and pain and loss of full motor function or movement. And when there's thickening of your nerve fibers, impulses don't travel as quickly or as effectively. So you have loss of, or at least slowed or altered neural conduction. The physical impairment is going to depend on the level of the spinal injury. Most common spinal injuries are going to be C5 through 7, so that's cervical spine, that's in your neck. And then at the level of T12 in your thoracic spine. I hope you guys remember from anatomy how many ribs you have. That's low down, your lowest thoracic rib. And then L1, your lumbar spine, at the top of your lumbar spine. The reason these are the most common areas for damage is actually because they are the most flexible areas of your spine. So imagine if you're in a car accident and your body gets thrown. It's those movable parts that can fracture, twist, sever, or pull. C1 to 2 injuries would be less common, but high up in your cervical spine, that's right where your spine meets the brain. And damage up there can sever your vertebral arteries and parasympathetic nerve pathways. Your parasympathetic nerve pathway up here at C1 to 2 also controls respiratory. So injuries up there can be fatal. They most likely are fatal. So here is your vertebral column labeled. You've got your cervical spine, thoracic, lumbar, sacrum, and coccygeal. What I want you guys to know from this slide is, in general, what these areas control. So your neck, cervical spine, movement and posture, really posture and head control is what's managed there. If you have a patient coming in with damage to their thoracic spine, particularly lower down like C6, 7, we worry about the respiratory reflex. Remember, your diaphragm is down there at 6 to 7. And so if a patient has injury to those thoracic ribs, they may not be able to breathe. And so they may need assisted breathing. Lumbar spine, just loss of movement to that lumbar area. But sacral spine, if you have damage there, these patients may not be able to control urination or defecation, so they may soil themselves. In addition to the spinal column, potentially being the bony substances being cracked and fractured, we're talking about nerve damage to those areas. And the nerve damage can be temporary during the immediate period, but they can also be permanent. So long-term care of these patients, if you've lost control of urine and bowel movements, that's going to be life-changing for a patient like this. Okay, shifting gears a little bit, we're going to look at a couple of specific clinical models, cerebral palsy, multiple sclerosis, and then very briefly on Parkinson's disease. Cerebral palsy, literal translation of that, cerebral or cerebrum refers to the brain, and palsy is Greek for paralysis. So this is a group of non-progressive disorders of movement and posture that originate not in the periphery, but in the brain. And what we mean by non-progressive is that this injury occurred at one time, damaged the motor tracts or motor control segments of the brain. This is not something that, like with Alzheimer's or Parkinson's, that gets worse over time. This is a one-time deal that causes long-term damage, stable damage though. The causes of cerebral palsy, multifactorial, but this is something that happens in the fetal, prenatal, perinatal period. And a lot of my patients are at high risk for cerebral palsy. So anything that complicates normal growth of a developing fetus. So maternal factors are gestational hypertension, something called preeclampsia, or maternal hemorrhage, anything that alters blood flow on the maternal end that affects the fetus. CPD is cephalopelvic disproportion. That's actually when a baby does not fit and gets stuck and then doesn't get enough oxygen to the brain. Shoulder dystocia, when they get stuck at the shoulder level during childbirth, and also there's a lack of oxygen to the brain. Prematurity, there are so many different things that cause prematurity, but around delivery of premature baby, those events that are causing early birth can also impact blood flow to the fetus. And then we also see strokes in the fetal period. So any of these hundreds of potential causes that decrease blood flow to the developing fetal or neonatal brain can cause damage to the motor tracts. So 1.6 per 1,000 live births, it's a pretty high number. What's occurring in the brain, prolonged hypoxia, so lack of oxygen, insult to the brain tissue, which causes oxidative stress, the inflammatory cascade, cytokine release, glutamate, excitotoxicity, and then brain cell death. So these patients, these babies can come out quite stunned, limp, floppy. They can come out not breathing at all, not moving at all, and sometimes they need CPR. About 10% of all live births need full resuscitation efforts as a result of some sort of event that caused hypoxia. Types of injuries, hypoxic or lack of blood flow injuries in the developing brain happen in what we call watershed areas. And that just means that the hypoxia is in these tiny vessels, not at the main vessel. So in older people, you would have a stroke or a clot blocking the main artery. Here we have hypoxia that gets to these teeny tiny vessels, the terminal branches, and then you have subsequent cell death in that watershed area, which happens to be those white matter cortical tracts. Remember those, that's the communication area that has to do with motor function and movement. And so if that all gets damaged permanently, then you have lack of control of movement there. So we see this type of injury would be uncommon in the adult population, but we see it in infancy. These are MRI images of a baby after a hypoxic ischemic encephalopathic event. So loss of oxygen and blood flow to the brain where those that white matter motor tracts were damaged. So just looking at the bottom two pictures, and I know you guys are not accustomed to looking at MRIs, but on the left side, this time we're not looking at white bright spots. Just a comparison, the bottom left to the bottom right. On the bottom right, what it really stands out to me are the black butterfly shape in the middle. Those are the ventricles. And what's happening in this picture is that the brain tissue that was damaged has died and shrunk. So the brain is actually shrinking, and what's filling up that dead space is fluid. And this is a pretty grave sign in a child. That means that they've lost a lot of normal functioning brain tissue, and it's just CSF fluid in there. So I would really be worried about this patient having some significant motor deficits. So cerebral palsy symptoms, we do something called risk stratification after delivery. So when you're born, we assign something called an APGAR score, and we assess your your breathing, your heart rate, your tone, your activity, your reflexes, things like that, and we assign a score. If a patient has suffered hypoxic event, they are not going to have normal breathing or normal neuro responses or normal reflexes. So that's a patient that we would evaluate, and depending on level of severity, mild, moderate, or severe, they would stay with us for treatment. Often these patients, if they've suffered a hypoxic event, have seizures for a time. These are also patients that we would cool the brain on ice after an injury, if it was a severe injury. And that would be that 72 hours of cooling before rewarming and observing. But in the developing brain, any of you that have taken care of a baby, you would know that babies don't do much. They sleep a lot of the time. So it's actually hard to tell once the patient has recovered from that initial injury, whether they're going to be okay or not. It's not until 3, 4, 5, 6 months of age where they are supposed to be developing normal activity like smiling, cooing, movements, fine and gross motor movements. So we assign a risk category. If a patient is high risk, we're going to have them go to their pediatrician more frequently. We're going to have them go to something called neurodevelopmental follow-up appointments so that we can watch how they're growing. And then we're observing for signs that they are missing those normal milestones. So for every age group, every couple of months, we have a set of goals that normally developing children should be meeting, like reaching for a toy, sitting up, balance when they start walking, things like that. And then also fine versus gross motor movements. Gross motor movements would be big, bold movements like kicking and throwing your arms around. Fine motor movements are something called the pincher grasp, like what we call for babies picking up with your 2 fingers, being able to pick up a snack or a pea or something small. And those are your fine motor movements. With cerebral palsy, while some children may have cognitive delays, that is not typical. What we really see are motor function delays. Some can have seizures as well, and seizures are patients that have seizures as a result of their injury have worse outcomes. Okay, here are some pictures of children with cerebral palsy so that you can see, after seeing these kinds of images, maybe you've seen someone in your community that has cerebral palsy. If you recognize some of the equipment that is used. So motor or movement dysfunction is the typical sign. The most common type of motor dysfunction is what we call spastic, and that is defined as an inability of the muscles to relax. You can still control them, so you can make that attempt to move or walk, but the muscles are very, very stiff and tight. The back of their Achilles, the whole muscle is very, very tight and can get shortened over time. So very difficult time walking or learning to pull up and walk and do the normal things that you would do in normal development. Hemiplegia involves extremities on one side of the body. Diplegia would involve both legs, and then quadriplegia would be all 4 extremities, trunk and neck. Dyskinetic and ataxic are your much less common types of cerebral palsy. But you can see in the picture on the bottom right of this young gentleman, the way that his hand is flopped forward, it's actually very tightened and tense, and those muscles are tightened and shortened and really, really stiff and difficult to control. In general, cerebral palsy these are motor movement deficits, so they don't typically have cognitive problems. That means that they are wonderful kids with great personalities, normal intelligence, high functioning, just difficulty with the movement piece. And sometimes that motor component can impact their ability to talk as well. So they can have difficulty with speech and may need assistive devices to help with speech, but they are still very intelligent and really, really wonderful to take care of long term and spend time with. But you can see, like, getting to school, getting around school, and then when they get older, getting in and out of work. I mean, they need help. They need help with toileting, with feeding, and with just getting from here to there. So diagnosis of cerebral palsy, we don't diagnose it at birth, but we assign risk. So your APGAR scores, if you have low APGAR scores, and then you had metabolic acidosis, which would be a result of suffering hypoxia in the womb or around the time of delivery. And then we look for evidence of damage on MRI. The more severely affected children may also have organ system failure, and that is around the time of birth. So all of that is sort of acute, and then once they recover, if they survive, more severe damage, those kids don't always survive. But if they recover and they get over that initial event, and then they grow and go on normally, then we put them in this high-risk category for cerebral palsy. There's no cure for cerebral palsy. We have medications for seizure control if that's an ongoing issue, medication for muscle spasms, and then mobility aids, and then these kids need occupational and physical therapy and speech. So if cerebral palsy is a non-progressive neurologic motor disorder, so that's something that happened at one time and then does not reoccur, multiple sclerosis then is a progressive, debilitating neurologic condition, which is caused by degeneration or breakdown of neurons via demyelination in both brain and spinal cord tissue. So as a review, myelin is that nice, thick, fatty layer that coats your nerve fibers, and that allows electrical impulses to travel quickly from point A to point B. In MS, those fatty layers get broken down. While the specific cause is unknown, most of the evidence is pointing to this being autoimmune in nature. And we have evidence of that because in CSF samples, they're seeing autoimmune inflammatory markers, T and B lymphocytes, macrophages, and IgG, IgM, eating away at the nerve myelin sheath. Risk factors, European ancestry. Usually these patients are quite young, more likely to be female, and have a genetic predisposition. So if it's runs in the family, if you have any family members that have had it, that puts you at risk also. And then they're finding some other environmental factors that may kick off that autoimmune reaction. Recent viral infections, Epstein-Barr virus is one in particular that kicks off different autoimmune diseases, and certainly is one of those viruses that we worry about having MS risk. Smoking, low sun exposure, and low vitamin D are other environmental factors that are found with this disease. The manifestations or clinical signs of MS have what we call most commonly a relapsing remitting pattern. And what that means is you have bouts of CNS inflammation. So you have these acute flare-ups that alternate with periods of remission. So big flare-ups and then periods where you're not having any symptoms, and it can come and go, and there's nothing predictable about it. There's no rhyme or reason to it. Some of the signs and symptoms are all related to that nerve conduction or those nerve impulses slowing. So you can have vision loss, and because nerve damage doesn't happen perfectly symmetrically, what we often see is unilateral or one-sided vision loss, or maybe not complete loss, but like blurriness or dimming or loss of function. These patients can have cognitive loss or cognitive slowing, bowel and bladder dysfunction, and then movement, trouble with gait, feeling like your legs don't work, slurred speech, paresthesia, which is like a numbness and tingling in your periphery. So like numbness, tingling in your fingers and toes, and then very, very extreme fatigue and pain. So again, it happens in younger people. I had a very close friend who we were in our 20s, and she had been having symptoms of numbness and tingling for some time, but didn't think anything of it, and then just woke up one morning and her legs didn't work. I mean, she just couldn't get up out of bed, and then was quite debilitated for some time. And then, you know, a year later, she got all of her function back, but then she would have episodes again where she couldn't lift her legs. So that's that relapsing, remitting, recurrent pattern. Another way that this can happen is primary progressive, which is slow chronic deterioration. So not really rapid flare-ups, but just slow and creeping. And that usually starts with those paresthesias, meaning numbness and tingling, and then gets progressively worse. Diagnosis is through a medical history. They want to find out your risk factors. They'll do look for environmental risk, recent viruses. They can test for Epstein-Barr. They can do vitamin D levels, all of those things. They'll do a neurologic exam. This particular disorder it's difficult to diagnose, so they would rule out other things first. So they might do a CT or MRI to look for some other cause. And, you know, sometimes we find things like a brain tumor or something else that's causing numbness, tingling, weakness, loss of function. An LP is indicated here too. They'll look at your cerebrospinal fluid and look for inflammatory markers. And then they have these electrode tests called evoked potential testing. Some of them are auditory and some of them are visual. They'll put electrodes on you, on your head, around your ears, around your scalp, and show you images or sounds, and then measure the time from the impulse to when you heard it or when you saw it. And then they have normal, like, baseline values of how quickly your response should be. While there's no cure for MS, we do have a couple of drugs that seem to help a little bit. They can lessen some of the symptoms and lessen some of the suffering. immunomodulating drugs that impair host immune response, and then T cell blockers to protect myelin. It's those T cells that are eating up the myelin sheath as if it were a foreign invader. So blocking them from activity can be helpful. But just know that anytime you're taking any immunomodulating drug, anything that suppresses your immune system, now you're at high risk for infections because you don't have your immune system functioning at its highest level. Okay, so we don't have a lot of time to talk about all the other possible neurodegenerative disorders, but there are several, the most common being Alzheimer's and Parkinson's disease. And we do talk about Alzheimer's a little bit more in our last class where we talk about changes with aging. But these are progressive disorders, meaning they get worse over time and are primarily characterized by neuron loss or neuron damage. And so you have worsening symptoms. Some of the neuron loss is normal with just aging, but Alzheimer's and Parkinson's in particular are pathologic examples of that. And we have difficulty treating these disorders because of that blood-brain barrier. So that BBB protects you and keeps medications that aren't supposed to be there out of your brain. It keeps up to 99% of all foreign substances out. And that's why it's really, really hard to find effective medications that can cross that barrier. Alzheimer's primarily affects language and memory. And Parkinson's affects problem solving, speed, memory, and mood. One unifying feature in both of these disorders is the accumulation of damaged proteins in the brain. So there's a lot of research looking at how to combat that. And that's it for those disorders. And here's just a look at a different neurologic exam, so different from the Glasgow Coma Scale, which is for more acute neurologic dysfunction. This is something, and if any of you have gone in for a regular physical, we do this on growing children and then in adulthood, but maybe I'm just old and that's why they do that for me. Mental status checks, again, orientation to time, place, person. So do you know who you are, where you are? Do you know the date? Do you know where you are, what state you're in? Sometimes they'll ask if you know who the president is. And then memory, we have different memory tests, attention, judgment, language expression, sensory reflexes. We have the eye chart. We look at your pupil reaction time. You can test hearing, touch, pain, temperature. In a sick patient in the hospital, we would also check their gag reflex. That is not something you would do in a alert, active, conscious patient. Coordination and motor function, and then muscle tone and strength. So those are all the components of the neuro exam. And then just to end on a more positive note, the 6 pillars of brain health, not just for your brain, but this applies to total body health. It applies to cardiovascular health and inflammation in the body, but specific to the brain or different from those recommendations. Actually being social, having a friend group or a family group keeps your neurons high functioning. Engaging your brain in lifelong learning. Actually elderly patients that don't engage in stimulating activities actually decline much more rapidly. So I know you guys want to hurry up and finish school and start your lives, but as you get a little older, you'll find that engaging in increasing or continued education, or just finding things that are new and fresh that interest you can help your brain continue to grow. Managing stress, and then all those other good things, exercise, eating right, and getting good sleep, are also critical to brain health.